Dr. Phil Wagner, welcome to the Pain and Performance Podcast.
Thank you for having me.
Much appreciated for doing this. This is probably one of my favorite topics, as some of the listeners will know, other than diving into the kind of science on cell health. We're going to talk a lot more about the physical side of things, I think, today. I thought I would kick this off. I would love to get your kind of ideas and philosophy around the components of physical health. Like, how do you think about physical health as a whole?
Yeah, I think the first piece is when we look at physical health, we kind of define it, I guess, selfishly or not, as we look at it movement health. And we define movement health as the ability to move without pain or fear. And I think, the pain part most people recognize as like, yeah, I want to not live in pain. The fear part's interesting. Even in sports, there's this with athletes called kinesiophobia. And a lot of times you're at risk for secondary knee injuries because you had an ACL injury and you're scared to have another one. On the other end, working with seniors, we found the greatest predictor of falls a lot of times is the fear of falling, because you stop moving or you change your gait to have shorter steps. So that fear piece and that pain piece are really key to that movement health ability, not only when you're young, but also as you age.
That's, man, for such a straightforward answer, there's so much in there. I was asked at a conference one time, like, what the biggest thing that we saw when we looked at all our patients who recovered amazing from really complex issues, very complex disc herniations, complex nerve injuries. And after going through, we actually had the whole staff go through it. And the thing that we make note of is their kind of mindset around movement and recovery. And the biggest predictor, there was certain things that kind of hit in terms of like health demographic. Were they healthy before the injury that showed a better outcome? But the biggest one, the glaring one, was the people who had a better mindset around movement and recovery got better quite a bit, a whole standard deviation higher than the people who were afraid of it to start.
Interesting. Yeah. I think that's a big piece that's sometimes overlooked. We want to look at the structure, right, and the direct, more concrete issues rather than this mind-body connection that is real and in fact probably more impactful. This is kind of an aside. When we're trying to maybe measure something like that, is that a questionnaire that you would look at in terms of like a fear of movement? Yeah, it's a great question. Surveys are much more powerful than people realize, and I think it's interesting. A lot of statistics, the root is in psychology and psychiatry, because the data a lot of times is subjective. So how do you make subjective information more valuable? And a lot of times it's having better statistical methods. But these surveys, even something like what's called an RPE, rating of perceived exertion, has outperformed heart rate sometimes as a metric of difficulty and recovery, right? And that just speaks to that power of a survey being able to provide useful information on gauging how someone is moving or recovering, or how hard an exercise was.
Yeah, it's so interesting, and this is why I'm glad we're having this conversation, because if we look at that, the fear, the psycho-emotional component of this, we've had surveys that have been studied, and like we've gotten to a point where I think there's quite a few that have been standardized to show when the survey changes, something has changed in the body or the mind, right? And then from a chemical health standpoint, we've been doing studies in terms of testing chemical health for ages, of like, we're doing blood draws, we're giving compounds, we're doing blood draws, and we have these very scientific and standardized way of measuring both of those. And then we get to movement and movement health. And you look at the way we've been measuring this and trying to tell people how their movement is, And a lot of what you see is like somebody sitting back and saying, raise your arms over your head. Okay, squat down. And, they're jotting down what they see. And we're asking you to do manual muscle tests. And that's the epitome. Maybe we're doing something like a functional movement screen where we're watching and we're giving them a grade by watching them do it. Can they do it at all? Did they do it perfect? And then something in between. And that's the epitome of measuring movement for us. Can you talk to the problems with that and maybe what we need to do about it?
Yeah. Yeah, absolutely. Yeah, I think, you mentioned the functional movement screen, which is a great construct of, how to look at movement. But to your point, it's very subjective. You watch how somebody does something and you grade them, 0 through 3, how much quality that movement had. We work in the NFL Combine, and they use the functional movement screen, and I watch as some of the trainers, they're on the floor for 12 hours, grading 300 players on functional movement screen. I don't care how good of a trainer you are, your eyes at hour 11 are not the same as hour 1, right? So
absolutely.
There's a challenge, with any practitioner of, what state you're in yourself is going to impact how you see a movement. The other piece of that is you mentioned the manual muscle testing. I always joke because they call that the Oxford scale. And people are like, wow, that's really impressive, right? It's coming out of Oxford. And it's like, well, that's just pushing my hands, right? So, it's interesting that a lot of the testing we have, to your point, doesn't really have a lot of granularity or objectivity to how to measure something in a very standardized way. And I think the other piece to it is you want to have something that's frequent. We look at things that are really effective. Probably heart rate's one of the best ones, right? In that it's frequent, right? It's granular, and it's standardized. And particularly with a lot of wearables coming out, it allows a great way to track, your nervous system, your cardiovascular system, and how that's changing or not changing over time. But we don't have that for movement. And when you try to think of something what's close, the closest you can probably come to is like body fat or body weight.
Yeah.
But that's not really function, right?
Right.
But it's kind of the closest granular, standardized thing we can come to.
This is probably a large question. Is it that we didn't value movement throughout the last, 50 years that we haven't? Because I feel like, there's been some technology there. We've been having video games that were tracking movement to create it for 25 years now? So was it that we haven't valued it, or is it that hard for us to get something to measure movement consistently and accurately?
Yeah, I think it's a little both. I think certainly it's movement, is hard to measure because it's complex, right? If we think about something like a balance test, it's part neurological, right? It's, in terms of can you sense if you're off balance and correct, right? But it's also part structural, right? Do you have stability in your foot, like in your hips, and how all these different systems in the body are interacting to create a quote-unquote better movement. So I think that's part of it. But the other part is, we're also in a very capitalistic society, and so what financial return is movement, right? As opposed to like, well, if I'm moving poorly, and I'm in pain, I can just take a pill, right? And there is some sort of, quick fix and financial return for different parties, right? So if you're moving better and you're having less injuries and less appointments and less healthcare, like who wins there? So
only the citizens who are doing better. Let's not worry about them. That's not
it's
scalable.
An altruistic outcome, right? So, you can't cash in altruism a lot of times, and so I think, there's a mix of the healthcare system, but also, just in general, the complexity of movement, how do you find something standardized yet holistic at the same time?
I'm gonna hold back on this, but I'm gonna put it out there so I remember to do it. Because like, if we started to look at what, going in the future, if we could just say we have the technology, I want to circle back to like what would be the perfect way of looking at this stuff if we could get every measure that we could. But let's put a pin in that for a second. I'd like to deconstruct movement for a little bit with you and kind of go into, some of the stuff that y'all are looking at. So like from our standpoint, when we look at movement from a health perspective, what we're trying to do is we're trying to say, do we have the mobility in the body to move it the way it's supposed to move? Do we have the stability to control those movements through space in the world that we live in? Do we have the strength to kind of function with some of that stuff? And then certainly we kind of look at the pyramid of cardiovascular function. That is what allows us to kind of sustain the movement. So when we go through it in that aspect, do you think there's an order that people need to go at if we're trying to get healthier? And when we're looking at getting a baseline for, certainly for this conversation from the kind of mobility, stability, and strength aspect, how should we be getting that baseline and measuring those? Does that make sense?
Getting a baseline around movement or just around the system?
I think around both. If we could get a baseline, like one thing that's tough is like, how do you measure stability for somebody? Like standing on one foot with your eyes open versus your eyes closed gives you a black and white. Can you do it? And you need that in your daily life versus, can we measure that better? Does that resonate? Does that make sense?
Yeah. I think a key piece that we look at is how do you find a movement that is holistic enough, yet granular enough where you can take action. And I used heart rate before. Heart rate's a great kind of example, right? Or a blood draw, right? You can get a blood draw for everything from monitoring blood sugar with diabetes to cancer and how treatment's working, right? So it's a beautiful kind of gold standard to look at of, okay, you can do one test with hundreds of markers, thousands of data points, millions of data points, and split it up and dice it however you want based on data. I think we've got to look at movement assessments the same way. Can we find a one way to kind of capture something? And the way we look at it is balance is critical and probably the best one to do that. It applies to everybody from, a young child to a senior. And and the difference is there's going to be just different pieces within that. If I'm coming off a traumatic brain injury, right, balance plays, right? If I'm a 75-year-old that's frail and at risk for falling, balance plays. If I'm a baseball player and I have to make a fine adjustment to a 95-mile-an-hour fastball, balance plays, right?
Yep.
And, so one of the ways we look at it is if you do an assessment like balance, you should be able to glean thousands, millions of data points using sensors, and from that balance, you can take all that data and tailor it and group folks based on what population they're in and what their goals are.
Let's dig into that. So let's go through what that would look like. So what are those data points? We're measuring balance. Like, let's start with some of the people who are listening to this. It's the 50 to 60-year-old. I move pretty well. I've had some pain issues and stuff. How can I use balance to tell me about what's going on in my body, and how are we measuring that?
Yeah, ultimately balance is, you're trying to hold a position, right? And then if you get off balance, right, which is everybody will at some point, right, in an assessment, then how finely you can correct. And we generally see, kind of those two problems. If we look at someone who's more frail, they just can't hold that balance well initially, right? So that's a good place to start. Hey, just being stable enough to hold that initial set position. But then, the kind of the next level is that correction piece, how well you can control, any sort of imbalance. And that's where other processes like neurological processes start to be involved. Can you sense where you are in space and recorrect? And so the way we look at it is we look at sway, and that actually is that first piece of how well you can control that initial position. And then we look at control, which is, okay, you're going to get off balance. How well can you correct back? And it's, in a way, another way to think about it is bottom up, top down. Bottom up being that sway, that, stability, and then top down being that control to make sure you can control how movement may bring you in directions you don't want to go.
Yeah, it's fascinating to think about, like, the kind of the balance and stability. A lot of it, we think people are, when they have it, they're really, really kind of stable. And I think some of my patients think that means, like, I never get off balance. And my question, like, I show them, I don't know if you've seen this, we're all Saints fans down here, but if you've seen those videos of Alvin Kamara where he's like standing on a, like, not a Bosu ball where it's a half ball, standing on the actual full exercise ball, and he's catching, the little triangles that have a different color, and in the air, the trainer is yelling out a color and he's having to catch that color while he stabilizes on this sphere, and he's moving all over the place. And I'm like, look, he's not staying in one position. He's actually moving out and in of that position so much, but that's how good he has gotten, is that even when he gets off, he's got the ability to correct at a, superhuman level. I'm not asking you to do that, but if we can take that and bring it into where you're taking a step and there's a toy there and you have to move out of that normal position, now your body has the capability of doing that, and we don't just completely, crumble the whole system because that one little kind of kink comes in there.
Yeah, no, you're right. It's a resonance, right? In that you don't want to, we like to say, you don't want to be a 2x4 where you're rigid and not moving, but you don't want to be, a noodle either where you just fall and can't recover, right? So you've got to have that, a little bit of give, right, to correct. And so, a lot of times, that what we see in neurological issues is actually you become more rigid. So folks that have Parkinson's, TBI, or just aging in general, you actually lose that ability to have a little bit of responsiveness. And it's actually a biomechanical, term and definition called movement variability. So it's very much like HRV, heart rate variability, in that you want to have that responsiveness to your movement to be able to actually, to your point, like the Saints example, like be able to move and then return and have that fluidity. And that's really what you're going for, is movement shouldn't be stable, movement shouldn't be mobile, movement should be fluid.
So with what y'all are doing, let's kind of bring this out for people to kind of understand how, like, what's the technology that you're using to assess that? What does that look like?
Yeah, it's actually just a balance test, and what we've done is we've leveraged more recent technologies, like we use a force plate, which is a sensor that folks stand on, basically a little bit larger than a weight scale, and when you stand on it for 20 seconds on 2 feet or 1 foot, it picks up about 1 million data points. And so it takes those 1 million data points like blood draw and is able to look at things like sway, your control, and break that down to norms of what is, what should be expected and where areas can be enhanced. And I think that just wasn't possible before because, our data science, competencies weren't as high as they are now, both with the people in the space, but also the technologies. And so it's able to actually consume and store and make sense of much more larger data sets.
It's interesting because as you're saying that, I'm thinking, like, if I watch someone stand, somebody comes in and they're saying, like, hey, I've had some issues, and I'm watching them stand. I'm picking up a lot, right? I'm picking up posture.
Yep.
I'm picking up asymmetries in the body. But if you broke that down, I might be looking at, and I'm probably, on the high level of this because I'm looking for these things. It might be, I might be doing a disservice, 50 to 100 things. If you really said, like, what is all the stuff that you saw through their body by watching them there?
Yep.
And for you to say, like, we're picking up 1 million data points of what's going on with them, you're like, this is where we're failing, at least where we're suboptimal as those in the movement sciences, in the physical sciences of it.
Yeah, and I think to your point, an interesting study I read a few years ago is, going back to that Oxford scale, the push into my hands manual testing, they found more advanced practitioners were less reliable on it because they actually know more, right? And they're able to pick up more things, and it just becomes harder for the human brain to prioritize and actually put a number on those, because as actually you get better, right? What's that saying? Like the older you get, the less you know, right? You're able to see so much more, and it's harder to make sense of that. Whereas if you're a younger clinician practitioner, you may only be looking for one thing, and you're able to identify that one thing, but you may be missing things as well.
One of my favorite kind of quotes that I think about a lot lately is, like, as the island of knowledge grows, the shoreline of ignorance does too. And it goes to what you're saying. Like, you're experienced, you're brilliant, you're doing all this, you've been doing it for 20 years, and then you have preconceived notions, and I've seen this before, and you kind of jump to the knowledge that you have, and probably do, as that study says, other things less optimally, let's say.
yeah well, it just becomes harder to balance, right, all those different domains that you've kind of accumulated in terms of knowledge.
So when you're looking at somebody balancing on the force plate, we don't have to go through all 1 million data points, but I'm assuming in my head what's happening is you're looking at the pressure from left to right foot if they're doing 2 feet, the pressure forward to backwards, diagonally, how often they're switching from one side to the other, how much time they're spending from one side, like all of these things, not just on the surface level, but also like in between, in terms of like saying, how much pressure. So not just, is it more pressure left and right? It's to a finite degree, it's this much more pressure left to right. And then what happens after they do that? Is that kind of the metrics?
Yeah, and you kind of keyed in on 2 themes when you were talking about that. One is, the rate or the time, right? How fast some of those things are occurring, right? And that's key. How fast are you moving or not moving? The other part you keyed in on was directional, right? Where is that movement occurring? Is it heel to toe? Is it left to right? And looking at, not only the rate of those changes, but also the direction of those changes, right? Because that starts to elicit what we call a signature, right? Everybody has this movement signature, and those signatures can be insightful into, what types of things you can be doing, but also what things that maybe you shouldn't be doing that will further create asymmetries.
So if I'm going to kind of take this through there, if somebody comes in, what would be, if we can just kind of go on almost like a case study type of thing, like, you have, and I think maybe it'd be good to illustrate this on both levels, but let's use like a non-athlete, normal person who's getting assessed for this. What would be the analysis of that? Like what information does that give somebody? And I equate this to like a blood draw. It's great to get all these metrics, and I give that to a patient, and they're like, thanks, doc. Mm-hmm. I don't know what any of this means. I don't know what I'm supposed to do tomorrow with this information. So somebody comes and they get assessed. What would be some typical things that you would glean from that? We're on the most basic one, but we're diving into it. Like somebody standing, what's some of the stuff that you can pull from that?
Yeah, I think the major metric kind of at the top level is what's called sway velocity. So when you stand, your sway is how much you're moving and from that set position, that center of pressure position. So if you move very quickly to the left and you move far to the left, right, your sway velocity is going to be higher, right? So you really want to minimize that sway velocity. That's one, top level metric. Another top level metric we kind of hit on conceptually earlier is movement variability. And the metric there is called entropy. And entropy is really the same calculation as heart rate variability, HRV. So it looks at, how regular and those adjustments are happening. And you actually want them to be irregular because that allows that measure of responsiveness to being off balance. So those are kind of two high-level metrics. And then you can layer in almost subsets of those of, okay, well, is my sway velocity happening more left to right versus heel to toe, right? And is it happening more early in my balance, or is it happening later when I'm balancing, right? Because then you can look at, well, when as soon as I pick up my right foot, I sway a lot. Or after 5 seconds, I start to sway more, right? So, it's working off kind of those two high-level metrics and then the subsets within those.
It's brilliant. And you answered kind of my question is like, and I think HRV is such a brilliant way of matching that, because I think a lot of people on the surface would say, I don't want a ton of movement variability. I should be stable.
Right.
Same thing, like if you told somebody, hey, your heart rate is varying from beat to beat, they'd be, oh my gosh, like that doesn't sound good. But then you dig into it and you're like, that's how comfortable your body is in that. Exactly. That it's okay kind of letting it get off. I imagine there's a window that we like there.
Absolutely. There's this resonance that, I think like a lot of medical metrics, biomarkers, if you will, have that resonance, because the reality is most markers, just like on a blood test, you don't want to be too low, but also there's a risk for being too high, right? If your vitamin D is low, right, you obviously want to raise it, but there's vitamin D toxicity, right? It can be too high, right? And so, and that even everybody says, well, LDL, like you want to keep it low. You do, right? But you also don't want it too low because LDL makes up cell membranes, right? So, it's these biomarkers have more of a resonance of here's your therapeutic window, if you will.
So let's keep going with kind of the case idea. Like if we see that and somebody has, let's just say they're having a higher, kind of sway velocity towards one side. What does that mean for them? What does that mean for them as the manager of their own physical and movement health? What do they take from that they could come back and retest and say, not only is my test better, but this has led to A, B, and C in my life?
Yeah, I think, if one area has a higher sway velocity, if I've got a higher sway velocity to my left, that means I have less stability on my left side.
Right.
And that could be because of leg dominance, just that was developed over time, or that can be an injury. And so, training movements that focus more on that is going to be the most impactful, and that will then allow you to, be more stable in any other gross movements that you do. It can be so simple of if I'm doing an exercise program and I have a lower stability on my left side, I might be doing, if I'm doing 6 repetitions, 3 on one side, 3 on the other, I might do 4 and 2, 4 on my left side, 2 on the other. And so it's getting down to, adjusting your current program to like emphasize those areas that may be underserved.
It's brilliant. We had a patient who came in who had been seen by a few practitioners, had injections and stuff, who was getting like right-sided sciatic pain. And everyone kept telling him, like, look, you're overcompensating. You need to strengthen that side. You need to make sure that, you're getting good core stability and start doing all these exercises. And I said, well, have you done a strength test from left to right? Let's see what's going on. No, I have never done that. So we took him through a full strength assessment, checking both sides. So he was having pain on the right side. His left side was 30% weaker than his right side. So they kept telling him, strengthen your right side, strengthen your right side. He already had this major asymmetry where the right side was so dominant that he was constantly compensating for this weakness on his left side, causing all this pain. So of course, I'm like, look, we can go in and do, some advanced treatment and release all the tissue around the sciatic nerve, but you got to fix this. So he starts doing the exact training you're talking about of like overload the left side. Let's make that thing start catching up. Within 4 or 5 weeks, his pain's like 95% better. He's like, occasionally I'll feel it. Okay, now let's do some little bit of treatment and we clear the 5% up. But had, like he used your assessment, it sounds to me like that would have been right away. Hey, look, your sway is obviously highlighting that your left side has a problem. Your pain might be on the right side, but your left side is where the functional problem is coming from. Did you catch some of that, Phil?
Oh yeah, sorry, there's a little bit of delay. Yeah, I think it's common, that we look at, to your point, we see, okay, there's right side sciatica, so the right leg's the problem, right? But the reality is, your right leg could be in pain because your right leg is weak, or your right leg could be in pain because your left, your left leg's weak, so you're using your right too much, right? And so it's this kind of chicken and the egg, scenario where you really actually, have to take this, like you did, take the step before, the symptom. And it's less about addressing the symptom and more trying to find the cause, right? One of my favorite sayings from medicine is, where it hurts, it ain't, and so just because the right side is in pain doesn't mean the right side's the problem, right? So we got to continue to look at movement holistically and approach the body as a system rather than the sum of its parts. Yeah.
I would love to see a study with y'all's stuff where you don't talk to the patient and it's just like, here's the assessment. Let's fix what the assessment shows. And then they have like their pain conversations, not with that practitioner. You can't talk about it. So they don't know what it is. All we're doing is fixing the functional problems with it. And then separately from that, what happens to their symptoms? I have a feeling that would be we would glean a lot from a study like that.
Yeah, because I think there always has to be this balance of, qualitative things like symptoms and surveys with data, right? And like we're talking about here, the pain's on the right side, but you identified that the strength is better on the right side, right? So, you got to take those two and say, okay, well, maybe the pain on the right side is happening from weakness on the left side, right?
Yeah. What are some of the major things that y'all see? Y'all have tested how many people at this point?
There's probably about 4 million scans. Yeah, probably over 100,000 different people.
Has there been like some huge things that have jumped out that y'all are like, this seems to be some of the big movement issues? Is there some stuff like that? I imagine that changes by population, but is there some stuff that you're saying, hey, look, everybody needs to start paying attention to this. We see this over and over again.
Yeah, I think it depends on there's a few, and it depends on the population. I think my favorite one in sports is, one of the studies we published was, how we looked at and were able to identify and ultimately predict elbow injuries from a jump, in pitchers. And, you're thinking, well, how is that possible? And we didn't go in looking for that. Machine learning models found that because ultimately, if you don't jump with your legs, you're probably not throwing with your legs, and you're generating all this power and energy from your upper body, which isn't really meant to do that. Your upper body is meant to transfer force, right? And so it kind of reinforces this case study that your lower body is, unless you're on the moon or in the water, you're ultimately affected by gravity. So your lower body dictates everything. And if you can't fix that, working on your rotator cuff as a pitcher, which is about the size of your pinky, isn't going to do anything, right? And, that's a great example from sports. On the other end with, kind of seniors, we recently at a long-term care facility tested a bunch of seniors, and they were really upset that their balance was low, like really upset. And they were upset because they're like, I don't get it. I walk 6 to 8 miles a day. They've got Fitbits or they got other sensors, and they're like, I walk 6 to 8 miles a day. Why is my balance low? And they haven't done any resistance training, right? And so, the takeaway there is like, people will follow what's easy to be measured, like steps, right? Everybody knows, follow 10,000 steps, right? Or I want to walk 6 to 8 miles on my pedometer, but we've got to take a step back and say, okay, there's not a 1-to-1 ratio here of steps to balance. There's other factors that impact your balance. And so we have to look at things, again, very holistically, that the body is the sum of its parts. And those parts include the brain, but they also include, the different limbs that may or may not be impactful.
It's brilliant because you're talking about that, and I'm like, now y'all can have this point where you are not only like telling them where it's at, but you're also validating treatments to a degree. Like if a senior comes in and they can't balance, well, let's go and work on balance. But how did they do that? And did it change our retest? Which we right now, that's all subjective, right? I mean, not all y'all are doing it, but in the past it's been subjective.
Yeah. Test and retest is a great, kind of framework a lot of times, rooted in physical therapy of like, hey, we're going to do something, we're going to test, we're going to do something, then we're going to retest it. And a lot of times that's where the frequency of movement assessment is really powerful. Because, a lot of times if you do any sort of manual testing or movement testing, maybe it's once a year, and or maybe it's a brief time when you're going through rehab. But you want to have that validation because there's two parts that we see. One is how do you actually identify, and classify what people need or don't need. But it doesn't end there because everybody doesn't respond the same or as you would expect, right? And we see that all the time in pharmaceuticals.
Yep.
Right? You make a diagnosis, you give a medicine, but maybe they don't respond like you would expect them to. Movement's no different. There's a diagnosis, some sort of intervention's done, and you expect it to work out like that, but it doesn't always do that. So you need this retest from a movement standpoint to validate, hey, are these interventions working on this person like I would expect it to?
Is that so? My question is like, have y'all noticed stuff with that? Like on balance, what were the more effective ways of improving it on the retest?
Yeah, I think a lot of times the most impactful things are in people that are exercising. A lot of times it's doing less, and I think we all gravitate towards what we enjoy. So the second pattern we've noticed is, for example, I mentioned the seniors and walking. They may enjoy that and are unfamiliar or wary of doing resistance training. So they like walking, they do that, that's all they do, right? And so this validation says, okay, you're walking, but you're not actually getting better functionally. So you've got to maybe reduce your walking and add in some of these other things. We've seen it with sports teams. A few years ago, we saw a sports team dramatically improve their movement on the force plate. And we called them up. We're like, wow, we haven't seen this. What are you guys doing? And they said, well, it's pretty easy. We used to train 3 days a week. Now we're training 2 days a week. So, it can be very macro like that, of like how to set up your exercise schedule. It can be more micro level of what types of exercises you're doing and is it have enough variety.
That kind of goes to the old adage, like, if you took all the people out of the yoga studio and put them in the gym and all the people out of the gym and put them in the yoga studio, everybody would be healthier. Yeah,
absolutely. Yeah, exactly right. I mean, and a lot of times, we get there's a lot of jokes when people get assessed and they see the results and what they should be doing, and they say basically all the stuff I hate. We're like, yeah, exactly. That's what you should do.
That's why you hate it, probably.
And sometimes that's where data can be helpful, right? Is it's saying, hey, what you think you should do, but you're not doing because you hate it, you need to do it.
Yeah, and then
but
let's retest.
The good part is the retest can then validate if you are going to make the effort to do something you may not like or you're not familiar with. The data can then say, hey, see, I told you, that helps, right? And then then you see habit change.
Yeah, I mean, we're competitive beings. I think, the reason, this gets a little bit kind of maybe controversial, or I think the wording of it might be different from person to person, but the reason we've gotten to this area as a human species is because I think we're wired to improve stuff.
Yes.
And so when you gamify some of these things, it naturally makes us want to get better. I don't care if you're 88 years old and you show them that their balance is not good. Inside, you're like, bullshit. I'm going to get that better.
Yep. Right.
So
absolutely. And I think, and particularly in the American society where everybody is so competitive and more is always better, right? And so it does create, and I think it's one of the issues that, with data and wearables, we've got to be a little bit careful of, because it has started to create, and reinforce that more is better. If I did 10,000 steps last week, then I've got to do 12,000 this week, right? Because, I always need to be getting better. The challenge becomes, even things like 10,000 steps, they're not really rooted in science. It's rooted in the 1950s pedometer out of Japan, the first one, which is translated from Japanese to English as 10,000 steps, right? So that became like the goal, right? And, a lot of what you and I've been talking about is about resonance, right? Okay, when you get to 10,000 steps, rather than doing 12,000, is there something else you might be missing, to add instead of pushing the envelope further of that one thing?
Yeah, I think that's something we talk with a lot of patients about. It's not just like do more strength training. It's like, let's set up your week so that you've got some strength, and then you've got some stability and balance days in there. We've got some mobility. We've got some cardio. Like, let's set up a lifestyle that actually gets you healthier. Not just in terms of like pain, but in terms of movement and longevity of movement.
Yeah, and that's a lot of, at least for me, behind some of the founding story is I was an athlete and I was good at lifting and I loved it, and it's what caused a lot of my injuries. And now, I don't like doing stability and mobility, but that's predominantly what I do. And I'm a lot healthier. I move better. I'm in a lot less pain, and I really don't enjoy it as much. But at the end of the day, I enjoy being healthy a lot more than, just that half hour, 45 minutes of exercise that may not be precisely what I enjoy.
Look, I learned this very acutely recently. I shifted this year to I'm going to go back to doing some lifting. It's been a while. I'm going to start moving some weights. And so I stopped doing some of my dynamic stability stuff, kettlebell swings, and a lot of upper body shoulder stability, and swapped that out for the old school bench press, lat pulls and stuff. And about 4 months into this, my throw, I played baseball for, whatever it was, 2.5 decades. And so my throw and shoulder started to get really lax. I'm like, I'm lifting more weights. This doesn't make sense. I pulled out that extra day of stability on it and added a strength day in there, and started to have significant shoulder actual laxity and start kind of losing stability in there,
right.
Which culminated, you pop the shoulder out of socket and you're like, okay, well, now this is a problem. What happened? Oh, I'm getting older. No, you're not. You just lost a vital part of your movement program that you need in there.
Yep.
So
and I think,
go ahead.
Absolutely. Well, another favorite story I have is we worked with a professional athlete, on a team for a while, and he had a history of hamstring strains, and he came up to me one day after a year and a half and said, I've been doing this one exercise for a year and a half, and I am so bored of doing it. And it had been a year and a half, and he'd been healthy. I said, when's the last time you had a hamstring strain? He said, 2 years ago. And I said, I'm sorry, I'm not sorry. And I walked away, because it's like we have to look at some of these exercises and movements. That's not the goal, right? That movement health, that's the goal. Like bench pressing more or walking more steps, that's not the goal, right? That's the process that leads to the goal. And we've got to make sure that we don't make the process the goal.
Yeah, movement health is not free. You're going to have to you got to pay the taxes.
Yep, that's right.
So were there like major kind of aha or issues along the way that pain is the great motivator, that you were like, this needs to be improved. This area of healthcare is not where it's needs to be. I'm gonna kind of figure this out. What stimulated the innovation that y'all are doing over there?
Yeah, I think it was, one was, recognizing that musculoskeletal issues and falls across all populations are not descending despite better knowledge, more data, right? But we see other things like diabetes, while still prevalent, is actually trending down. And it's because we have better education and more clear insights from data, and data that's gathered easier, whether it's a finger prick or a continuous blood glucose monitor, right? But with movement, we haven't, jumped, to that construct yet, where we're actually able to really leverage all the knowledge we have to actually reduce the impact. So it was kind of shocking to me. We've got all this information, but the same stuff's still happening, in fact, more often. And I think the other thing, impact, was really, as we started to look at things, recognizing how important the ground was in your interaction with the ground, as a key feature to how all that movement occurs. We talked earlier about, left to right, heel to toe, fast, slow, like how that interaction occurs ultimately flows up the chain to the rest of your body and dictates some of the consequences that could happen. Yeah,
you talked about like that. I think we work with a lot of baseball players, just with my history and some of the doctors on the staff, kind of same thing. And what you said about elbow injuries from them not using their legs enough makes a ton of sense in terms of if you're taking that and you're throwing like that, absolutely that elbow is going to be getting stressed more. You're forcing it to try to pick up the job of the giant, powerful kind of legs and trunk, and your shoulder and elbow is going to crumble at that. What are those other things that you can see from poor ground reaction? Like, you talk about an elbow injury. Is there some other ones that you were like, that's wild?
Yeah, I think a lot of times, if there's ankle injuries, for example, like the first step is to tape it or brace it, right? And that does fix a lot of times the ankle instability and sometimes the ankle pain. But again, the body's a chain. So you basically took care of that joint, but it goes up, right? So now your ankle joint, which is a ball and socket, right, has been restricted. So you put the force on your knee, which is a hinge joint, and in a way you're telling the knee, hey, you're a ball and socket now, right? So you got to move like the ankle did, because we're not going to worry about the ankle, right? So when we try to address and restrict things and avoid the problem, if you will, we actually create another problem, and sometimes a bigger problem, further up the chain.
What would y'all see on, like, if someone, let's say somebody does have a rigid ankle that's not moving, what would that look like in their, like, standing assessment?
Yeah, you'd see them falling over, because, the ankle is really is one of the primary shock absorbers, for movement. If you sway to your right, you've got this ball and socket joint that can swivel and pivot and allow you to move back, to the center. And because it's so close to the ground, it can react a lot faster. Whereas if you take away and make that ankle joint more stiff, right, you're asking your knee to do something that it's not really meant to do. And there's not only going to be a delay, but potentially even an inability to regain that balance.
Yeah, I gotcha. What would you kind of, and I think this might be good for people to almost picture a little bit, What would, if you could take someone through, and I'm sure y'all do this, what's a full assessment look like? Like
Yeah,
if we're trying to get as much of the data as possible, we've talked about like standing and balance, but like what's the extra stuff? What's a full Sparta assessment look like?
that's it. Balance.
Balance, stand.
We have individuals stand on 2 feet
Okay.
first, and then progress to 1 foot. So that whole process takes about 2 minutes. So what we've tried to approach it is like, let's have more depth rather than width.
Gotcha.
And the reason we do it is for 2 reasons. One is the more tests and batteries you add, then the harder it is to crowdsource data from different locations, right? Because you're asking all these different locations to have a longer assessment time.
Yeah.
And then it also makes a challenge for the reassessment. So what you want is like, much like the blood draw example, a very small requirement of time to get that information, but also get it frequently, because you want to identify at the beginning what the dysfunction might be, but also how that changes over time, that longitudinal piece. So then the demand is you better find a sensor and way to suck as much information from that small amount of time as possible. Again, much like the blood draw. Sometimes, right, you go get a blood draw, there's like 12 vials, and in a way, that's what we want, is to have maximal information from a short amount of time.
Yeah. So for y'all, where do you see this at in like the kind of grand scheme of movement? And this probably goes a little bit back to what we were talking about kind of earlier. And like, if we had all the technology in the world and we could assess everything from a movement health perspective, like where is this at in that? Because you're gleaning a lot of information, but on the surface, I'm like, it's the start. Like it's the start of the tip of the iceberg, so to speak.
Yeah, so I think we've been talking a lot about assessment, and obviously balance being I think most would argue is probably the best singular movement assessment. But we also can't forget that there's exposures and activities that will make the information from the balance, different. And by that I mean you and I can do a balance test, we get the same, let's say score and information relatively on the balance test, but if I've got a history of ankle sprains and you don't, or if I've got a history of other injuries, you don't, if you're older or younger than myself, like there's all these other information, like if I'm not exercising, but you're exercising every day, right? So it's taking those other data sets and then adding it to assessments to really actually make it more powerful. And the good news is a lot of those things aren't necessarily difficult to find, just starting with age and gender at birth, right? It's those 2 things right away are incredibly impactful. Even in the military, we look at MOS, which is their job occupation, right? And so we work in the Air Force. People are like, oh, that's cool, you work with pilots. Not everybody in the Air Force is a pilot, So we work with fighter pilots. We work with drone pilots. They're very different.
Physical requirements are a touch different in those days.
Totally different, right? Exposure is totally different. The Air Force is trying to keep pilots healthy because they want to do too much, and they're trying to engage, drone pilots into a culture of fitness and get them moving more because they're sitting all day like a desk worker, right? So we talk about age, we talk about gender, we talk about occupation, activity levels, right? So it's combining all those other demographic and activities with an assessment. That's kind of the future, and it's what really requires more of a platform to bring all that in.
Yeah, you kind of touched on it. I'm like, what does the future look like for this?
Yeah.
As we go forward, like, what do we end up with a decade from now? What does this look like for the general population in terms of them being able to actually kind of find out where they are and how they're improving or not?
Yeah, I think the future is, a platform, a movement OS, a movement, data platform, if you will, that is able to take in assessments and sensors and your own personal history and activity. And from all those things, it's able to initially tailor recommendations, but more importantly, adjust those over time, right? So as you change, as your body changes, and as other people's information is being brought together, we've got this data platform that's learning and being more and more precise about what you need, because the value of all this is it gives you time. Because a lot of what we do in exercise, we may not need to be doing. I mentioned earlier, the improvements from training 3 days a week to 2, right? If we can actually, get to this XR pill, extended release pill, right, with exercise, and here's exactly what you need, don't do this, right? People will actually be more compliant and active because they recognize they only need to do these things and not have to do everything.
Yeah, yeah. Do you think there's a point where this is, I know we're kind of getting into like the future ideas, where this is something that people have access to in their home, like they can kind of, hey, look, it's time for your monthly assessment. You look at, some of the inside tracker ideas. These are stuff that we used to think would almost never be accessible for people to have this information consistently retested every quarter. We know that if we can make people lazier or lower the barrier of entry for these kind of things, the utilization goes up. Is that something that this can get to that point?
Yeah, and a big part of that, I think, is the movement we're seeing with health in the home. I think, the country is realizing, hey, hospitals should be reserved for people that are really sick, and for very complex procedures. Other than that, we should try to start moving things into the home, and initially that's driven by cost, right? It costs hospitals a lot, to have someone in a bed overnight.
Yeah.
But I think more importantly is, if it can move into the home, to your point, it lowers the barrier because you're actually able to access it as a patient, as an individual, frequently, daily, weekly, as opposed to once or twice a year when you go in to, see someone in a clinic.
Yeah. The exciting part for me, this kind of the researcher brain, is like, if you can do that, the data points and the what are you doing to pile, like right now you talk to 2 people and you check them, you're like, oh, maybe that's helping, maybe that's not. Like you're saying, if you're doing 100,000 people or, 1 million people, and we know what they're doing and they're retesting, the value of not subjective, we think this helps physical health and function. It's like, no, here's what these people with these initial tests did this, and it brought this. Like the research implications of this, of actually telling people, hey, 100,000 other people like you fixed it like this, is incredible. Something that I don't know that we have anywhere near some access to that type of information today.
I lost you there, Derek.
Oh, okay. Yeah, the research implications of this is quite exciting for me in terms of like how to pull
absolutely.
all that information in.
Yeah, and I think you're starting to see it with some of studies that Apple, for example, is running with the Apple Watch. A lot of times with research, we're restricted by recruiting subjects and having those subjects not drop out over a short amount of time, right? So we look at, hey, let's look at fall risk in the lab, and we've got 20 subjects, we're looking at them over 6 weeks. Apple's like, hey, we did this study with 30,000 individuals over 2 years, right? So big data is already overtaking the ability of the restrictions that exist with 4 walls, right, in a clinic and a lab. And those things are important because a lot of times the lab can still get us more of the granular details as to why, but there's so much more access to scale with things that can go beyond, a clinical environment.
One of the things that I heard you talk about that I thought was quite brilliant on one of the podcasts that you were doing was that if this gets implemented in the clinics now, what it shifts the time from of the practitioner is, instead of them spending a lot of time on the assessment and trying to figure all this stuff out, they can then kind of get into what it all means much more, which it's fine to sit there and tell a patient all their problems, but they leave saying, holy crap, like it sounds like I'm falling apart.
Yeah.
Because that's probably just a time thing. We can't spend a lot of time. Can you talk to the implication of being able to spend more time on the analysis of the information?
Absolutely. Yeah. I think, there's certainly a little bit of fear with AI and machine learning and technology with practitioners. This fear of I'm going to be replaced. And if that fear is, that it's going to replace your ability to do assessments, good. You should be scared, because the machine should do that better than us. The machine always should assess better. I mean, we're not scared about MRIs, or CTs, right? It's getting all this information in a short, targeted amount of time. And movements and other assessments should be no different. And we all know as practitioners, too, the main challenge isn't the assessment. The challenge is behavior modification, right? That's the hill we got to take, right? And so using technology to, alleviate us of the time spent on the assessment allows us to spend more time on the analysis and the education of that information that allows us to address the real obstacle that many of us don't want to face because it's hard, and that's behavior modification. How do we help individuals change their schedule, change what they do to become healthier human beings?
Yeah, so have y'all implemented this in clinic, in the medical office? I'm sure y'all are working with institutions and stuff a lot, but
yeah. In fact, one down by you with Ochsner Health System.
Yep.
It's used to help capture information even on healthy people initially. And then also that can be helpful, because if you're capturing healthy people initially and an injury does happen, when they come in, you've got this baseline already set to say, okay, well, we saw you when you weren't injured, and here's how you moved. Now we see you, right, and here's what's changed. So we got a better idea how to address that.
What does it look like in let's say an outpatient? I don't know if y'all have that. What would that look like in an outpatient facility? Would the patients come in, you take a screening, and then the next thing they do is they're going and they're getting on the force plate and getting an analysis done, and then the readout is given to the practitioner?
Yeah, the simplest way to do it in a workflow is just replace the weight scale. So a lot of times patients come in and weigh, right? Well, if you can weigh in and get 1 million data points at the same time, in 2 minutes, right? That makes an easy part of this workflow, both outpatient and inpatient, to not really disrupt that workflow, but arm the practitioner with, functional information and more information that allows them to either start or validate the interventions they have.
What does the practitioner training look like? About 40 to 50% of our listener population are practitioners on some level, which is wonderful to have amazing guests like yourself to be able to come and kind of get some of these information into the medical community. For them, how much of a learning curve? Because if you're looking at all this stuff, to me, I'm like, that might just look like a bunch of squiggly lines to me. I don't quite know what y'all's printout looks like or what it does, but how much of a learning curve do they face?
Yeah, I think with any technology, at least good technology, it should be layered, right? And the value of that layering is there's no bottom, to the information, right? So at a high level, it can be, here's your balance, here's your sway velocity. Just like a wearable, like here's your sleep, here's your heart rate. Now, there's layers to say, okay, which direction am I sway? How fast? Or what is my resting heart rate versus my max heart rate? And so there's right away on the first day, the learning curve is pretty short to be able to capture and use that information. Now, to better understand it and cater it and learn more, there's layers to educate and dive deeper out of curiosity, but one of the things we're excited about is, this whole sharing of information and technology isn't about, hey, Sparta's going to figure out these new things, and we'll tell you when we figure them out. This is so much of a partnership of, we've got great clinicians, practitioners with eyes everywhere that are constantly giving feedback. Hey, I'm seeing this a lot. What do you think? Right? And this is that shared learning, which ultimately elevates, I think, the profession and healthcare in general.
Yeah, yeah. That to me is the real exciting part about some of these things, is like just that it's a constant improvement cycle.
Yes.
The more who are using it, who are giving feedback, we're getting better data. And like we were talking about earlier, like who actually wins in that is the person who we're working with, is the citizens.
Yeah, absolutely. And I think, practitioners ultimately have a great opportunity to start learning as well, because we're all seeing different patients in different regions and have different perspectives and biases, and by kind of sharing those, there's so much cross-functional education that can be had from each other.
So back to our first question. If you had the perfect movement assessment system, like y'all have got the kind of the ground reaction force probably covered, what would that look like to you? If I was like, any technology, we can snap, it's here. What would be the perfect assessment to check all the layers of movement? Hang on, you're muted. I'm sorry. I was like, this is going to be a great answer. Are we missing it?
No, yeah. So I think the perfect kind of assessment or, future that I would see is, we've got this regular, very quick balance assessment that's occurring longitudinally, but there's also this plug and play scenario where you're able to take your information, whether it's from a sensor or injury history, medical history, and you're also able to plug that in to alter, those assessments based on your own history and own desires too. Like if you're like, hey, I'm 50 years old and, here's my balance test, but I'm going to plug in my wearable and my medical history. I also want to plug in, hey, I want to go skiing in December, right? So you're able to match up history, assessment, current state, but also future goals, right? So how do you, whether that's short-term or long-term, right? And so by bringing all those things together, you really kind of create this Sherpa, if you will, to have a great, long life of movement health.
Yeah, it's so good in terms of, being able to take that and take action with it. You talk about that person and they get on there and it shows, hey, look, you're having some weakness. Go do, some strength training. Maybe your left side a touch more than your right side, and come back next month and we'll tell you if you need to ramp it up because you only got 5 months left till ski season.
Yeah, absolutely. Yeah.
What about landing? I don't want to get this too off, but like landing, if somebody does like a single leg hop and lands, how much are we able to see, certainly from an athletic population, injury risk kind of skyrocket with that? I know that's something that we've looked at a lot.
Yeah, we used to do a landing test. Mm-hmm. One of the benefits of starting in sports and athletes is they're ultimately the best cheaters. Right? They'll find a way to cheat anything if it's within the rules, or if it's not within the rules, they'll find a way because they want to win, right? And so when we rolled out this landing test, what we noticed, we gathered data for like 4 years, is they would find ways to, maybe start closer, to where they had to land, or to actually step into it rather than jump into it, or, they would find all different ways to make the test appear better. And so what it required then is someone actually, a practitioner there on site to make sure it was standardized and adhered to. And that just isn't scalable, to do frequently enough. So while landing is a great, I guess, movement to look at, it's the way we look at it is it's more of a prevention or performance tool rather than an assessment tool because of its ability to be manipulated differently, and then it becomes hard to compare. Did some people do it the same way as others? Whereas like something like a balance, it's like, okay, well, you either picked up 1 foot or you didn't. And on our system, at least, if you don't pick up your foot, it won't start the test. Or if it says pick up your right foot and you pick up your left, it won't start the test. So a lot of that was from athletes. I mean, we had an NFL team where a player was coming off ACL. He had a player take the test for him so he could pass injury. And so we even had to put in these markers where it measured, okay, is this body weight actually you? So people couldn't take the test for you. Yeah.
Leave it to athletes.
Standardization's a big piece. Yeah.
So how much are right now, or is it pretty standardized, like the protocol on it, or do practitioners, could they add like, hey, do the standard protocol, but then I also want to see what happens when you do X? Is that something the system can actually do right now?
There's a free run system that allows like other tests to be done, which could prove valuable, could not. The challenge becomes is there's not as much, you lose the crowdsourcing value of like, well, everybody may not do the test.
Yeah.
But certainly there's a way to do that. Yeah.
I'm thinking about it like kind of from a practitioner standpoint. I feel like I saw a picture of somebody doing like a plank on it.
Yeah.
On the force plate, and I was like, man, that would be, like in my office, we do a lot of kind of trunk and lower body assessment.
Yep.
And one thing we've looked at is like we don't have as good of techniques to really get asymmetries front, back, left, right from the upper body and the neck. So I saw that. I was like, man, that could give some interesting information.
That's another one that got cheated because, then athletes started to make their feet really wide. And we did it at the combine, and linemen who are fairly heavy started doing downward dog rather than like plank, right? So it became, it's. I feel like sometimes with athletes, it's this arms race of testing of like, you figure out a way to prevent cheating, they figure out a new way to cheat it, and like it's like blood testing in the Olympics. Like, yeah, it's constantly leveling up.
It makes me think like when we're talking about like the perfect thing, if markerless movement technology could get to a point where it really gave us good data of what was happening to the body in space, and we could do that while they're on your force plate, so we can see all those things while we're matching up. I mean, I feel like we might need a supercomputer for something like this, but man, that sounds quite enticing to me.
Yeah, markerless movement I think is great potential for almost all movements. The challenge is when it comes to balance, if your goal is to not move, then it becomes difficult, with the markerless capture. But with other movements, tracking other movements, a squat or some of the things we were talking about, FMS, I think it's fantastic, to be able to track the quality of movements. But it really would struggle, at least on the balance side, or any goal where it's really to not move. Because the markers aren't hopefully moving that much.
You would at least get that alignment has got, hey, your ass is 12 inches too high. That's not going to work.
Yeah, exactly. Totally. Yeah.
Phil, this is brilliant. I love what y'all are doing, man. This is such good stuff. Where can people find more from Sparta Movement Sciences, and where can they find out more about what y'all are doing? If practitioners are looking for more information on this, where can they find that? Where can they find some of y'all's videos? I'm going to dig into them after this. I think I was telling you before we started, I didn't want too many preconceived notions, so I haven't watched a whole lot of it. But where can people get more information about what y'all are doing?
Yeah, the best place is our website at spartascience.com. And so Sparta Science, we've got everything from case studies to blogs around topics and movement to research publications, and kind of really the spectrum of, depending on the interest of individuals and the topic too. It can be anything from how to improve your 40-yard dash time to elderly and falls.
Beautiful. Do y'all do conferences or anything like that? Do y'all get out there and kind of showcase the technology and the analysis from it? Do y'all have any of those things coming up?
We usually present at conferences every year. We used to host our own conference before COVID, so we're looking to, have that back again, hopefully towards the end of the year or next. But yeah, I think that's a big piece is, interacting with other practitioners and clinicians at these events, to really kind of start creating this community where, everybody's kind of building off each other's perspectives and insights.
Beautiful. Yeah, we'll put any of the information in the show notes for those of y'all listening. If they've got some stuff coming up, definitely check it out. Phil, we ask all of our guests, if somebody listening to this could do one thing today to improve their health, what would that one thing be?
Yeah, I would say, the pause is really that, being a data guy, it is so individual. But I think, what data should do, if you have any data, is it should help us reconnect with your intuition. Because I think our intuition around movement is very strong. Like, the things you shouldn't do, and the things you probably should be doing more of. I mean, you talked about it with your shoulder, and so I think it's really making sure that you listen today to your intuition on what you should do, because it's likely right, and that can be anything from resting to maybe doing less strength, more walking, or less walking, more strength, right? So really kind of, trusting that intuition, even if it may be uncomfortable or maybe less enjoyable.
That's a great answer. I think that's the first one we've got on that one. Trust your intuition. You probably know what you're supposed to do, guys and gals. Listen to that today. Dr. Phil Wagner, this has been amazing. Thank you so much for coming on. Keep doing what y'all are doing. I think the future is extremely bright for Sparta and what y'all are doing, continuing to really kind of approach this with the right idea of let's improve, let's learn, and constantly be keeping that cycle going. Thanks for the energy and the information y'all are putting in the world, man.
Thank you. That was great.
Much appreciated.